Welcome, my dear colleagues, residents, fellows, and of course, my dear viewers on MuniMeterHealth, your source of learning cardiology and about human heart. This is Dr. Jaitly from New York, your cardiologist. Today, very briefly, I want to bring you to your attention, your kindest attention, something latest that has been just recently discussed at the American College of Cardiology meetings that just concluded in March of this year. Two breakthrough trials for TAVR, which is the transaortic valve replacement, and the two trials which just were published in the New England Journal of Medicine in March of 2019, which is last month. One was concluded from Cornell, Columbia Presbyterian, where I trained as a fellow a long time ago, and Dr. Leon and the group are from there, and the trial is named after Partner 3. It's the Partner 3. And the Houston Methodist group is the second trial, which was also published in the New England Journal of Medicine in March of 2019. It's by Dr. Reardon. And here it is known as Evolute Early. So Evolute Early or low risk rather. So these are the two trials that have just been published. So the breakthrough information is the following. Well, first understand what is TAVR. TAVR is the transcatheter aortic valve replacement, as I've written it down, and these are bioprosthetic valves. Both are bioprosthetic. The configurations are such that they fit into the aortic valve with the least compromise on the aortic flow profile. So they're highest competent valves which have been studied over the past 10-12 years. And one is by the Sapien company, which is Edwards, and I'll write it down here. And it's the Model 3, and another one is by the Medtronic. Now, the valves I've shown here in a longitudinal section. This is a cross-sectionals, but they both look very, very similar. Obviously, they are coming out from two different sources. The very fact that the two valves were studied in two different trials and we have similar results. Dr. Eugene Braunwald made a comment at the end of the discussion out of this, is clearly stating that we have not only the acceptability of the two valves as double, but it has been quadruple because it has been shown in two different trials. So again, I quote Dr. Braunwald that this is a very, very historic moment in cardiology history, that in the past 50 years since the first valve that was performed in 1962, and that was a surgical aortic valve replacement. Remember, all these trials, they are randomized and they're comparing this procedure, the minimally invasive procedure TAVR against the SAVR. So we are looking at TAVR versus SAVR. So when you compare the surgical aortic valve replacements and versus the transaortic valve replacements, these are minimally invasive, and the whole idea is wanting to see if we can actually perform these surgeries with minimal surgery, minimal morbidity, and minimal mortality. So up until now, the largest randomized trials that concluded in the past 10 to 12 years clearly showed that extremely high risk, that means very, very high risk patients, or patients with intermediate risk and moderate risk, they were all qualifying for TAVR, and the results were better than the SAVR. So TAVR was already showing either non-inferior or at least definitely superior to the SAVR in terms of lower risk of mortality, lower risk of morbidity, earlier hospital discharge, and lesser ICU days, and quicker return back to the daily activity. So all of those findings were clearly shown in the high risk and intermediate media risk. The question that was remaining to be answered up until now was whether can we do it for the low risk aortic stenosis patients. Now remember, TAVR is being recommended for all aortic stenosis patients. Now let's understand what aortic stenosis is also briefly here while we are discussing this. Here I'm drawing a schematic of the heart. This is your right side. This is your left side of the heart. And as I'm drawing it, you'll see the aortic valve, which is right here, that's where the stenosis occurs. So the stenosis occurs here, the aortic circumference that the valve is narrow or is stenosed. So this is aortic stenosis. We call it AS. So AS up until now was being performed by SAVR, which is the surgically aortic valve replacement, and has been, as I said, was first performed in 1962, and you know the technique was mastered up until now by the transthoracic surgeons. What has happened in the last 10 to 12 years, the transaortic valve replacement, which is the minimally invasive procedure, it's a non-surgical technique. Now, how is it performed? It is performed through the groin, just like the cardiac catheterization if you were to do. And here I'm drawing the two iliac vessels, you know, and then merging up into the aorta, the descending aorta, we call it. And of course, here you have the femorals. So it's from the femoral artery, the right femoral artery. If it is inserted, it goes up almost like in a collapsed umbrella fashion. It is ascended all the way and then dropped through the aorta, through the arch of the aorta, and back into this position. The patient is under general anesthesia, is in a cath lab or in the operating suite, if you will, and these patients are now getting this valve replaced, and with minimal surgery. So the only scar that the patient walks home with is a small little puncture in the groin. There is no median sternal sternotomy, if you will. There's no open heart surgery. There's no heart-lung machine bypass involved here. So you're looking at minimally invasive surgery being performed with these valves. Whether they are the Edward Sapien 3 or whether they are the Medtronics, depending upon which trials you're looking at. So these trials really concluded that the low-risk aortic stenosis patients, who are the 80%, who are about 75 to 80% of the entire aortic stenosis patients being recommended for surgery, those patients also performed extremely well. So it's not only now indicated for the high risk and intermediate risk patients, but it's also indicated for the low risk aortic stenosis patients as well. So the findings clearly concluded that there is a lower risk of CVA or a stroke or an MI or a death if these patients were followed for 1 year. There was decreased hospitalization. There was rehospitalization rates also went down, as a matter of fact. And the patients returned back to daily activities rather very quickly. In fact, they used the Kansas City Cardiomyopathy Questionnaire, KCCQ, to assess those activities. I mean, you don't have to remember all of that. But the fact is that, if you looked at the atrial fibrillation, the new onset atrial fibrillation rate were also reduced in these patients markedly. The only caveat here, I would say, or maybe two caveats here, is the incidence of placement of a permanent pacemaker went up slightly because the new onset left bundle that developed in many of these patients as compared to the SAVR group. So that was one. And the second caveat was, of course, the finances. Financially, it is extremely expensive. So because these valves are markedly expensive. But over a period of time, I'm sure the finances will definitely go down, because as the cost of these valves get lessened, and other companies are producing similar valves, and hopefully the cost will go down. But I think as the techniques improve and the experiences improved over a period of time, the chances of your new onset left bundle branch will also be lessened over a period of time. But again, we know that the bundle is actually sitting right here. We can draw it in a similar, because the left bundle just comes right next to, as it's traversing into the septum, if you will. So this being the right bundle, and this being the left bundle. So these bundles obviously can cause can be interrupted, and when they are interrupted while you're doing the aortic valve, you end up giving a permanent pacemaker in these patients. So that was the only caveat where there was an increased incidence of pacemaker insertions. So I'll just write pacemaker here. Insertion went up in these patients, and of course the finances or the dollar cost is much higher in these trials. So once again, friends, just so that you know, everybody understands now that even for low risk aortic stenosis patients, a valve replacement is possible with a minimally invasive technique, or non-surgical technique, if you will, or I should say, where patients actually live longer. There's a greater chance that they'll walk out of the hospital on third day. There's a greater chance they will walk out of the hospital without an atrial fibrillation, without having a stroke, and returning back to their daily activities also rather fast than with SAVR. So the whole idea is that TAVR has been now shown to be markedly superior to SAVR based on these two trials. One that is called the Partner 3 trial, the other is the Evolute trial. I refer you to the New England Journal of Medicine, where these trials have been published now, and both these trials have been done from Cornell and Houston respectively, and they've clearly shown that they are much superior to the SAVR, which is the surgically aortic valve replacement, up until almost 8 or 10 years ago, where this was the standard technique. However, the largest trials clearly only outlined that the high-risk groups and the intermediate groups were clearly shown to be beneficial by TAVR. Now, even the low risk has been first time ever shown to benefit from these two trials, as clearly concluded. So once again, I thank all these wonderful works done by Dr. Leon and Dr. Reardon, and appreciate so much great zeal and dedication to follow and give us this information to the rest of the cardiology world. So again, and of course, Dr. Eugene Braunwald, who is the father of cardiology, I bow to him. He wrote the textbooks, and of course, we follow that very closely. And I think it's a very historic moment, as Dr. Braunwald says clearly, that this is a remarkable feat that has been achieved through the TAVR trials now concluded, which have been recently published at the American College of Cardiology meetings. Once again, thank you for tuning on MuniMeterHealth. We'll continue to give you these cutting-edge technology information. Once again, it's an educational channel only. There is no prescription, or there is no recommendation that we offer. Just kindly note that. And again, we are primarily improving the medical education as also the patient education, so that we have a better clinical outcomes, and the clinical outcomes are clearly proportional to the patient health literacy. If we can improve the patient health literacy, I think we can do a great deal of service to our cardiology community. Thanks again for watching, and this is Dr. Jaitly again, once again, and so long, and looking forward to seeing you again on MuniMeterHealth. Bye now.